Yeah, it's yeah.
Good evening, everyone. Today's Wednesday, March 27th, 2019. It is 5:31. I'd like to call to order the meeting of the Central Health Board of Managers. The first item of business is citizens communications. Denise?
Hi, good afternoon. My name is Anais Cruz, Program Manager here at Central Health. We have 4 people signed up to speak during citizens communication. All 4 are aware of our process and guidelines. So with that, I'll go ahead and call up our first speaker, Carlos, and I'm sorry if I mispronounce this, but Zaffirini with Seton and Baylor.
Good afternoon. My name is Carlos Zaffirini. I'm the CEO of AHCV. I'm here on behalf of Baylor, Scott & White, and Seton Family of Hospitals. We are the organization that set up all 20 LPPFs across the state of Texas and have worked with all the hospitals in all 20 jurisdictions to figure out ways to get this done and to make an equitable outcome for the safety net. And our priority is finding programs that help support the safety net, that deliver access to care, that improve the efficiency of all the operations that exist. And so I thank you on behalf of Seton and Baylor Scott & White and as a local for looking at this as an option, because what we saw in the first 20 LPPFs was a marginalization of certain communities, especially in South Texas, in Northeast Texas, and Southeast Texas, all across the state. They were unable to access dollars, and healthcare outcomes were becoming worse and worse. The LPPFs brought equity to the program, allowed them to access the money that they were foregoing. I wrote down several things. You all had really good questions, and so I tried to write many of them and see if I could address them, and I'm also happy to answer questions. Obviously, the first 20 LPPFs are now 70% of all the IGT in the state of Texas. It's a big number. It is the dominant program. But I also want to make one point that I think sometimes we get lost in legislation, and the legislation just gives you all the option to create an LPPF. It is not a mandate. You all are charged with the responsibility of determining whether it's right for this community and for the safety net. And you set the rate, you talk to the providers that are subject to the LPPF and have to participate, and they have to, there are certain federal limits. You asked that 1396, it's 42 USC 1396B that addresses the provider tax regulations that govern LPPFs. So to the extent that these LPPFs, or the LPPF comes into this community, I think there was a question about the burden that it could raise for some of the other communities, or that could come to Central Health. It's actually, I think it could relieve some of the pressure, because, for example, you all have had a historical agreement that allows you to fund the UC programs and the district programs, and that's great. But the URIP program was funded by the LPPFs in Williamson and in Hays County, because the beauty of the LPPF is that it delinks the utilization of property tax revenue from the IGT. And in URIP, and soon to be UC, the IGT is delinked. And as a result, you have no control over where your property tax funds go. The LPPF eliminates that as a problem. Happy to answer questions if you have any.
Thank you very much.
Our second speaker is Elizabeth Colvin with the Dell Medical School.
Hi, Elizabeth Colvin with Dell Medical School. I wanted to make sure that you had seen this document. This is a report this is the second edition. We'll be producing this twice a year, every January and July, and it highlights the activities that Dell Med has in the community, and it shows the different ways we're impacting the community. And as you'll see, there's, Central Health is our great partner. A lot of these are done in partnership with Central Health. So I'll be back in July with a new edition and new highlights. Obviously, we're doing a lot more than what's on this document. This just has a selection. And my other goal for this year is just to keep you updated on these various projects that we're doing. So to hear from various speakers from Dell Medical School. So tonight, Catherine Jensen is here. She is a first-year medical student. She was previously in the Peace Corps in West Africa doing community health, and she had selected Dell Medical School to become a physician. So I will turn it over to her for her to speak.
Okay, I'm going to introduce Catherine Jensen with the Dell Medical School.
Hello, my name is Catherine Jensen. I'm a first-year medical student in the class of 2022. I know it's a little bit cheesy, but my goal as a medical student and a future physician is to help the people in my community. With that in mind, I'd like to tell you about 4 of the many community projects that my classmates and I are doing in Travis County, along with other medical students at Dell Medical School. First, we've partnered with the Texas Medical Association's Hard Hats for Little Heads program to distribute helmets to kids to prevent traumatic head injuries. Most recently at the Explore Dell Med event that was a part of Explore UT, we properly fitted helmets to 125 kids, and we gave their parents information from a physician on how to prevent head injuries. We've actually already seen kids using our helmets out in the community, which is really cool. My team has another event scheduled this upcoming Saturday to distribute 70 helmets at an underserved Title I school on the east side. Secondly, we've also partnered with the Texas Medical Association's BeWise Immunize program, coordinating a free Tdap vaccination campaign for adults in the Runberg neighborhood in Travis County. The 2017 Austin Public Health Critical Health Indicators report showed a disproportionately high number of cases of pertussis in the Runberg area. I received a small grant from the Texas Medical Association for this work. We just held our training class for the vaccination campaign. It was a joint effort with the UT School of Pharmacy, nurses from University Health Services, and nurses from Austin Public Health. It was the immunization unit, adult outreach unit. The campaign itself is planned for next month at the Gus Garcia Recreation Center in Runberg in coordination with Austin Public Health. And we hope to continue this vaccination campaign work in the fall with influenza and pneumococcal vaccines. And if all this kind of goes smoothly, then we hope to expand the program next year as well. The last event I want to share with you today is a 2-part disaster preparedness exercise. I'm sorry, this is the third one. The first part of the initiative included a Stop the Bleed training program on tourniquet use. This is aimed at enabling people to reduce mortality from motor vehicle accidents and other trauma. Our Stop the Bleed training for medical students took place in February, and students from that training are receiving tourniquets to carry with them. The plan is to continue this training initiative and expand it to include community members. The second part of the disaster preparedness initiative is a joint training exercise with the Defense and Veterans Health Consortium and 1st Air Cavalry at Camp Mabry this upcoming Saturday. One of my goals as a student with the Mabry exercise is to motivate medical students to get involved in Operation Lone Star, which provides free health services at the border in late June or July. This initiative is also aimed at strengthening our connection with Veterans Health. I could spend another 3 minutes talking about our work at CD Doyle. It's the free student clinic across from the Arch. Every Sunday, volunteer medical students, nursing students, social work students, attendings gather to provide free health services to underserved and predominantly homeless community members. In conclusion, thank you for your support of Dell Medical School. I selected Dell Medical School because of its commitment to the Travis County community and its goal to revolutionize how people get and stay healthy. I appreciate the opportunity to share the work I've been doing as a medical student here. Thank you.
Thank you.
Our last speaker today is JP Eichmiller with Central Health.
Good evening, Board. Tonight, it's my pleasure to present you with the fiscal year 2018 Central Health Annual Report. We have paper copies available over there, so please grab some, distribute to anyone in the audience or to your friends. We're also posting online tonight after you all have received this, and we are currently working to translate this in Spanish. So I get the privilege of producing and presenting this report every year, but this report is really about all the hard work of the hundreds of Central Enterprise employees, this all-volunteer board, and of course our community that puts in the financial support to support our most vulnerable residents in the community. I'm not going to go through all the details, I'll let you do that in your own time, but a couple highlights. Last year we provided 99,000 residents with screening for insurance coverage. More than 46,000 residents are enrolled in MAP. At Community Care, provided over 356,000 medical, dental, and behavioral health encounters for a total of 99,000 patients. And through the CCC and Community Care, we reduced access barriers by launching transportation pilots. And with Sendero, we provided hundreds of free meals to children and their families. Finally, one number I want to leave you with, 183,985. That is the total number of Travis County residents that we funded healthcare services for. This is a number we have never reached before. It reflects encounters in hospitals, in primary care locations, urgent care locations, specialty care clinics, all of our network. And it represents more than 1 in every 7 Travis County residents. I will also say it represents a significant amount of work on our end as far as data collection. It's evolving every year. We're getting better at it. And I'd like to thank all the members of our teams who spent countless hours to bring you all the information in this book. So thank you. Have a great evening.
Thank you, JP. On behalf of this board and Dr. Coopwood, that is a beautiful number.
Indeed.
Almost 200,000.
Yep.
Let's keep it growing.
What is this? What is this?
What's that?
What is this?
Yeah. Use them. Use them.
All that time? Younger days.
That concludes our citizens communication for tonight.
Thanks, Anissa.
Thank you.
All right, agenda items 7, 8 will not be discussed. Those items are agenda item 7, discuss and take appropriate action on Central Health owned or occupied real property, including the downtown campus, properties located in eastern Travis County. Agenda item 8, discuss and take appropriate action on healthcare services delivery expansion in eastern Travis County, including the project timelines. With that, we're going to go to consent agenda. Do I hear any motions to extract any of the consent agendas? No.
C5, please.
You want to extract C5?
Yes,
Okay.
please.
Then we're going to go ahead and vote on C1, 2, 3, 4, and 6. Let me read those out for you. Consent agenda item 1 is approve the minutes of the following meeting of the Central Health Board of Managers, A, February 27th, 2019. Consent agenda item 2 is receive a report of the February 2019 financial statements for Central Health as presented to the Budget and Finance Committee. C3, receive a report of the February 2019 financial statements for the Community Care Collaborative as presented to the Budget and Finance Committee. C4, receive the quarterly investment report and ratify Central Health investments for February 2019. And C6, approve an amendment to the agreement between the Community Care Collaborative, CCC, and Front Steps for expanded recuperative care services in an amount not to exceed $500,000 as recommended by the Budget and Finance Committee.
I move.
I second.
Sure.
I'm finished my motion.
Oh, sorry.
I move that the board approve consent agenda items C1, C2, C3, C4, and C6. Now you can say.
Second.
You second it?
Yes.
We have a motion on the floor by Manager Bell, seconded by Manager Musaitif. Any discussion? Seeing none, all in favor say aye.
Aye.
All right. Motion passes. Well, now we're going to take up consent agenda item number 5. Approve the nomination of Stephanie Lee McDonald to the Tobacco Settlement Permanent Trust Account Administration Advisory Committee.
Well, Chair, I think this is, again, referencing back to my other comment at our last meeting. We don't have a proper process in place. I just want to know how we appoint people to such boards. And so to me at this moment in time, and this is, again, I love Stephanie. It's nothing any kind of personal or anything, and the same thing that goes to Dr. Coopwood. I want a clear process in how we appoint and assign individuals.
Yes, ma'am. There is an executive committee meeting that I don't know if it's been posted yet or will soon be posted. But that's one of the items to bring to the executive committee to get some guidance about when we bring something back to the board. How do you want to set up this process? I think it'd be fairly intensive, to say the least, because some boards, like the Tobacco Settlement Permanent Trust Account Board, that's a very perfunctory type board. There's nothing really glamorous about it. No offense, Stephanie, but I needed somebody to plug in there. You were it. You're the first person I saw when I looked up.
Short straw drawn.
And then, yeah, she gets all the good assignments. And then things like the appointment to the Community Care Board, where you're directly affecting patient care. And so I think it's not as simple as just having a very, 5-step process. I think it's going to be fairly involved. But I need to bring that to the executive committee before I bring something back to the full board, because I need some kind of recommendation coming out of that committee.
And that is
But
really
that's
the reasoning
in process.
I asked for it to be pulled back, out of
Sure.
consent agenda. I just wanted us to really have a proper process in place, and also to ensuring that individuals, I know Stephanie has a load of work, and she is a part of many boards and on other committees, so we just don't want to overexhaust our staff as well. So, thank you. That's it.
Any other questions, managers? Can I have a motion then?
I move that we approve consent agenda item number 5.
Second.
Okay. So I have a motion on the floor by Manager Bell, seconded by Manager Greenberg. Any other further discussion?
Did we get an answer to her question?
Well, I think Mr. Giesman answered it by saying we're going to have an executive committee next.
Yep.
Well, it's going to be
It's in
posted
early April.
April 3rd.
Yes, sir.
And this item will be on there, there's your suggestion?
Yes, sir. And then I'll need to bring something, and just like we bring other issues through committee, I'll need to bring back to the board some type of process for you all to then deliberate about how we place individuals on boards.
But I just want to make sure, this is already, we'll approve it, it won't come back, so the.
No, I get that.
Future.
I concur with your question, so,
Any other questions? All in favor say aye.
Aye.
All against say no. Any abstaining? Motion passes. Thank you. Okay. Regular agenda. Agenda item 1. Discuss and take appropriate action on the resolution expressing support for legislation authorizing the creation of a local provider participating fund to be administered by Central Health in Travis County. Mr. Knodel and Ms. Crowley. Mr. Giesman's going to read the resolution first.
Thank you, Chair. Jeff Knodel, Monica Crowley. We just completed a work session related to legislation that's been filed around LPPS. Had some really good questions, good discussion, and we'll be happy to answer any subsequent questions that you may have. I think Mr. Giesman was going to read into the record the resolution, so I'll turn it over to him.
And members, the way this will work, I'm going to read the resolution, and then the motion will reference the resolution as I've read it, for parliamentary purposes. Resolution of the Central Health Board of Managers regarding local provider participation fund legislation. Whereas Central Health contracts with a network of safety net providers in Travis County to provide access to high-quality care to uninsured and Medicaid patients. Whereas local safety net hospitals in Travis County provide a substantial amount of healthcare services to uninsured and Medicaid patients. Whereas local safety net hospitals in Travis County undergo significant financial burden due to unreimbursed costs they incur in caring for these patients. Whereas a local provider participation fund would allow local safety net hospitals in Travis County to access available local and federal funding without burdening local taxpayers. And whereas certain similarly situated counties throughout Texas have been able to authorize and/or contemplating the use of local provider participation funds pursuant to enacted legislation similar to the draft legislation attached here to as Attachment A, to access additional funding for unreimbursed costs for patient care. Now therefore be it resolved that, one, the Board of Managers of Central Health hereby declares its support of legislation that would establish the creation of a local provider participation fund in Travis County, and the Board of Managers declares support to serve in the role of administrator for the local provider participation fund, and the Board of Managers of Central Health specifically supports language similar to the draft statutory language attached here too as attachment A, adopted on the 27th day of March 2019 by the Central Health Board of Managers, if adopted, signed by Guadalupe Zamora, Chair, and Abigail Aiken, Secretary, and then attachment A being the draft legislation.
And Manager Bell, will you make the motion?
I move to adopt the resolution just read.
Second.
Okay, so I have a motion by Manager Bell, seconded by Manager Greenberg. Any discussion?
Yes, sir.
Manager Valdez.
With respect to the creation of the board that will be responsible for overseeing the LPPF, how is that going to come down? How is that going to impact us? Are we going to be the ones responsible for that? How is that going to work?
Monica, Jeff?
I'm sorry, could you restate the
It's
question?
the Central Health Board is the administrator of the
So the
LPPF.
Central Health Board is going to be the LPPF administrator?
Yes.
Board
If you choose
for
to
the
create
SDA,
the LPPF.
for the
Board would have
service
to,
delivery.
sorry, I
For the Travis County LPPF.
Okay.
Right, and we have to remember, and I know it's kind of confusing because we combined two issues
That's right,
into
into
one
one.
slide, because for us, for our purposes here, our main concern with the LPPF is uncompensated care, so we believe that the illustrative, need was around uncompensated care. But the LPPF is really an LPPF for the private hospitals in Travis County, administered by Central Health.
So with respect to, if just a clarification on that, so with respect to the LPPF
Yes.
district, which would be all the hospitals within the 8-county area?
That's for
Oh,
us,
that's separate, that's separate.
yeah, that's
Got it, got it.
uncompensated care, that's the SDA pool, and that's an HHSC thing.
Okay, so I think you explained that. Thank you. I just didn't realize that we're talking about two
Yeah.
separate entities, and there would be no central health representation on the one for the 8.
That's
It
an
has nothing to do with
HHSC
Yeah,
mechanism.
that would be you.
Okay.
Right.
Manager Oliver?
Reading 1, 2, 3, the fourth whereas down, the final 1, 2, 3, 4 words without burdening local taxpayers, which I get because we currently use our taxpayer dollars to IGT. But it's not like they're going to get a tax break right now. So I don't know if there's a way that, do you see what I'm saying? Like the language kind of makes it sound like, hey, guess what, you're going to get a tax break, but we're not really. I don't know,
And
is there a way to massage that so it doesn't quite come across as, I get that they're basically, the LPPA is creating a provider tax that the providers pay that gets
Right.
IGT. It means that burden is off of us, but it doesn't necessarily mean a reduction of,
Right, that,
Can I,
yeah.
but
Manager Greenberg?
I think it was there because it's meant to say that taxpayer dollars are not going into this. And so we need to make that clear. And so that's why I think it says without burdening, because
They'll be IGT.
no taxpayer, none of our local property tax dollars are going into this. Is that correct, Jeff?
Correct.
And so was that the intention of that language?
Yes, would it help if we put with no additional
Yes.
burden?
To
Just
local
as a-
taxpayers? As an
Yeah,
amendment.
that's what I was saying,
Yes.
additional,
Yes.
yeah,
Slightly-
because,
Slightly?
yeah, because that was the point. It's
Yeah.
no,
Right.
Yeah.
Right.
Just to clarify that, so we're talking because the other hospitals would be paying in a proportionate share.
the only money to come
And
from.
that they would be putting the money in,
Yes.
not us, not our
Correct.
To
taxpayers.
reallocate those.
That's
IGT
exactly what I
dollars to
said.
other health
That's what I said.
So-
Just wanted to make sure I was clarified, I understood that. Thank you very much. Thank you.
So members, if we could get a motion stated directing us how you would like this amended, so that we can have it in the record in the minutes.
The way you said it, Monica?
So we propose, just on the fly here, as it relates, I'll read the whole paragraph, the whole whereas. Whereas a local provider participation fund would allow local safety net hospitals in Travis County to access available local and federal funding with no additional burden to local taxpayers.
I like that.
I think that works. I move that we go with Jeff's suggestion.
Holly, do I need to ask the question be withdrawn or just amend
No,
it?
we can amend it.
So we can amend it, and so I move, it would be a motion to say, I move to amend the motion just seconded by adding the words that were just said
Yes.
to the fourth recital.
Manager Greenberg?
I move to amend the motion in front of us by adding the language that was just cited to the fourth recital.
You have to ask the maker of the motion?
No, she's amending the motion.
I'm
Right,
amending.
oh, okay, okay.
I don't
So
think-
that's its own,
It's a friendly amendment.
it's our own vote, a separate vote.
Okay.
Okay.
We
Manager
can
Greenberg?
vote on the amendment.
Okay. Manager Greenberg made the motion and seconded by Manager Oliver. So we have to vote on the amendment first, correct?
Correct.
Any further discussion? Seeing none, all in favor say yes.
Yes.
Aye.
Aye.
All in favor, all against say no. Any abstaining? Motion passes.
Now we have to vote on
Now we
Now we have to vote
Now
on
vote on
the
the
original
actual
amended motion.
motion, because you voted to approve the amendment.
language.
So now we have an amended motion. Any further discussion on that? Seeing none, all in favor say aye.
Aye.
All against say no. Any abstentions? That motion passes. Thanks, Jeff. Thanks, Monica.
Thank you.
All right, agenda item 2, discuss and take appropriate action on proposed amendments to Central Health bylaws. Ms. Grumlet.
Good evening, managers. Tonight I'm going to walk you through.
Do you want to get a little closer?
Sure.
You can speak in the mic.
I'm going to walk you through the changes that I have made with input from some of the managers to the bylaws. I do want to recognize up front that since the meeting was posted last Friday, I have received additional comments from 3 board members, and so those comments are not reflected in the version that you see tonight, because what you have in front of you tonight was what was sent out last Friday as part of the board backup packet. So we may not be ready to take a vote tonight, but we'll walk through some of the more important changes, and then if you have any questions, feel free to ask them. If there are things that you have not told me that you want to change, tonight's a great time to do that as well. So I'm not going to walk through all of the changes. I think just like the Sendero bylaws, I'd like to go through the important changes that aren't really wordy, like wording changes, just because I think it sounds better. Let's look first in your backup packet on page 120. This is Article 3, Duties and Authorities of the Board. In section 3, there is a list of things that the board is allowed to do, so long as there's no prohibition or limitation imposed by law. One of the changes that was made, and that I know a manager has raised some concern with, is to 3B. So 3B used to say, approve the annual budget for the district and submit the budget to the Commissioner's Court. What my edit did, and as you probably can tell from my comment, is remove the responsibility from the board for taking the budget to Commissioner's Court. That has historically been performed by your executive office, Mike's office. But if you would like that language to go back in, because I know there is some concern, I don't see a legal problem with it. Moving on to A quick question related.
Sure, go ahead.
So if that language is removed, that means the board will not have an opportunity to be at the Commissioner's Court and to discuss the budget? No, so just like any open meeting, the board can go to a Commissioner's Court meeting, and I would say Mike would encourage you to go and be there to speak on whether you are in favor of the budget that you're presenting to them. This is just an administrative requirement of submitting an agenda request to the Commissioner's Court to put the item for approval on their agenda. So if the Commissioners Court had any issues with our budget, they go through staff and then the staff comes to the board? If you remember, we had, back to Sendero, whatever we had, that you wrote a memo, if you recall. So would that task be completely done by staff? Because I know we had some engagement related to the budget and the county. So I'm just trying to understand if there's any nuances with this, or is it just a administrative thing that it's the staff will deliver the budget? So I just wanted to clarify.
Yes, ma'am. And could you go back to the first part of your question? I want to make sure I understand.
The first part, so once we remove this language, the board will not be required to be at the Commissioners Court to answer any questions, because usually we're there. So that's the question that I had initially. So removing that language, would there be any nuances, any changes to the role that we're currently doing? That's really...
No, in fact, I would say that what you currently do now, which is exercise your option to be there or not, would still continue. That would not change your option or your obligation either way.
Okay, that was just,
Yes,
I just wanted clarification. Thank you.
Manager Walden.
Holly, thank you for doing this, and we've spoken about that. And I personally would rather see the original language remain, and because then it makes sure that we have the ability to exercise our fiduciary responsibility and have those discussions, and especially with respect to operations and our budget and the enterprise. So I personally would request that it remain in place.
Thank you.
Alright, so moving on to page 121, still in Article 3, now we're looking at Section G. I have removed, this used to say, approve and enforce the policies, procedures, rules, and regulations for the operation of the district. And the reason that the words procedures, rules, and regulations were removed were twofold. One, I believe in January, Patty Miller came before you and you approved that policies would come to the board, but procedures would be handled by staff. So this is a consistency edit. The other thing is, currently the board doesn't have rules or regulations that it actually can adopt and impose upon Travis County residents. So if we leave it in there, it's harmless, except for the procedures, because that would conflict with what our action in January did. Moving on to K. K talks about a philosophy and strategic goals for the district, and I have added language so that we can define what the strategic plan is, because we use the phrase strategic plan in the strategic planning committee responsibilities, but we've never said what a strategic plan is. So that is my attempt to capture what a strategic plan is. And if you have wording suggestions at the end of this, I'm happy to hear them.
Can I ask a question? You're going on to the next item?
Yes,
Did you remove all of I?
I did.
I'm sorry, you removed all of I?
Why?
This is something that I personally feel does not bode well for us to leave in, because we have not done this. So essentially we have a policy that we weren't following. We haven't done biennial board self-assessment since I've been with you in 2015. If you want it to stay in there, it can. It's a best practice not to have language in a document that you don't follow.
Correct.
Why shouldn't we do that?
Well,
Manager Weaver.
question, is there anything that would prohibit us from doing this if it were not included?
No.
Okay, so maybe it's best to err on that side of, if we want to do it, we can, and we'll start doing it, but to have it in there and not do it, I agree, is not, I believe is not good from a policy standpoint.
What is it?
I'm sorry.
Is that sending a message to the community that that's not a vital part of our role by removing it?
We haven't done it.
Well, I know we haven't done it, but the question is, the fact that we haven't done it doesn't mean that we cannot
We can't do it.
let the community know that we believe this is vital. I'm not opposed to either way, I'm just
Yeah,
saying, I was wondering why it was removed.
Yeah, but that's Mr. Giesen.
So I'm going to come back to, actually, if I could go in reverse order, but come back to what Manager Greenberg was saying. You all did an assessment sometime last year, I believe, but it wasn't a biennial assessment, as council pointed out. It's a biennial assessment on what you do every 2 years. And so, you all had done this sort of thing. You would not be precluded from doing something like that or something much broader than what you've done before. Manager Jones, I think in terms of the signal to the community, I would argue this, that it goes without saying that a board has to pause every so often when new members come on board or there's a big change coming up, that you stop and assess where you are. And there's many times you wind up doing that just a matter of course of business. For example, when you all adopted a revision to the strategic plan, you go through a lot of inward-facing assessment in terms of where the organization is and what you all as a board are doing. I guess the last thing I'll say to this, and just in terms of the optics of this, every 2 years is a long time.
It is.
Especially with how things change rapidly, not only the composition of the board, but what happens in healthcare. And I think that stepping back, like at the annual retreat, like what we had last year and what you all are going to have next month, is a good time to step back and do that level of assessment. And so, in some respects, you're potentially sending a stronger signal. But those would be my observational comments.
Manager Greenberg?
I didn't make a suggestion. It does not appear to me that we're going to adopt anything tonight. So maybe what we need to do is go back and think about this language. And I agree. I certainly wouldn't want to say that we're only biannually examining how we're conducting our business. And so I would suggest that some group of folks, whoever's going to work on this, look at that language and determine if there's something else or better that should be in its place.
So, Holly, do you want to go ahead and finish, and then maybe we can ask for a motion if they want to set up an ad hoc committee?
That would be my recommendation. Yeah.
So actually, when we get to the committee language, it's not something that you need a motion for.
Okay.
So it's your prerogative as chair to set up an ad hoc committee. What the board would vote on is the members. They would approve the members that you appoint to that committee.
Sure. Well, do you want to finish all the amendments to bylaws first?
It's really up to you. I can continue to go through, and if you have questions about that particular thing, we can stop and address them.
Manager Valdez.
I apologize, but on going back to G, where you eliminated procedures, rules, and regulations developed for the operation of the district, otherwise to get delegated to the president and CEO, I understand that that's the administrator's role for the development of appropriate procedures, rules, and regulations. However, one of the things that I have advocated for historically is a conflict of interest language that would include revolving door policy and addressing or talking about possible appointments to boards and commissions, or if we have staff that sits on boards and commissions, how is that a conflict or not a conflict? So with respect to G, and in knowing, for full disclosure purposes, that I have been speaking with both Holly and Patty, who's the compliance officer, about such language, there are two options for us to address that, and that could be I think it should be in the bylaws, but there's a fallback position that it would be included in procedures and policies, but then we would have to have that ability to allow for us as a board to make sure that that is included in policies and procedures, because otherwise we would have lost that ability to influence that and then maybe correct or resolve some issues that are outstanding. So I would ask that it go back to the original on G. and, and, and also look at, I guess it's M, almost in the same vein.
So, Mr. Giesel, what I'd like to do is go ahead and set up an ad hoc committee. And that way we can have the board managers can
I think it's a good idea.
discuss this.
We can't get through all this tonight.
Yeah, that's right.
Yes.
So who would like to be on this? Do we need to do it now, or should?
Purpose of the ad hoc committee is to do what?
To review the
Through all
bylaws,
this.
like we're doing here.
Okay, so to do what Holly has already done, but more thorough with board involvement.
Right.
Yes, sir.
And it's probably going to be lengthy, seeing how we're going to do it, so you'd want a subcommittee of this board to then report back. Is that correct,
Correct.
Mr. Chairman?
Is that correct, Mr.?
I'd like to volunteer.
Manager Valdez volunteering. Anyone else like to
I'll
volunteer?
help.
Thank you, Sherry.
Manager Jones and Manager Greenberg.
Yep.
How many should we have? No more than 4?
No quorum.
4.
Yeah.
Mr. Chairman,
Mr. Giesel?
May I ask a question, Counselor? As people are contemplating their involvement, is there a particular timeline by which this needs to be done?
The only thing that I would say, and I know we haven't gotten here, is there were some discussions about changing the downtown campus committee to a fuller real estate committee to consider all real estate matters, not just downtown campus. So the longer we wait to discuss these things, the longer it takes for us to actually have a real estate committee.
However, if I may ask, is there,
But there's no legal timeline in which we have to
and then
abide by.
under the current bylaws, if there is an ad hoc committee set up, do they have to batch everything up, or can they kick out various issues like the one you just mentioned and go ahead and make that recommendation to the board, as long as there's not any interdependencies amongst other bylaws?
Yeah, so we can amend the bylaws as many times as you like. It's not a fun process, but yes, it has been done before.
Yes.
So if there's something that you think needs to be done urgently right now, we can come with that recommendation
Thank you.
first and then come back.
Appreciate that, thank you.
Thank you.
Given that I chair that committee, and I think we have a meeting next week, so perhaps if we're all in consensus, if we're all in consensus on that item, to amend the bylaws to include the whole.
I'm not sure there's consensus. Bob.
I'm sorry?
I'm not sure if there's consensus about any of the bylaws. I think
That downtown campus, that's the one item that I think we can amend, not to the rest of the
Change it
bylaws.
to real estate.
That's the only amendment that I'm proposing to, if we can take a vote on.
I'm not sure that you have a consensus tonight on that, Maram.
Is there a reason? Just out of curiosity, I know we have other, and I also want to share some of the changes that I requested, and given that you've asked for an ad hoc committee, I cannot be part of it due to time commitment. So can I share?
Sure.
Yeah.
And so I've submitted a few changes that I would like us to adapt or consider with this proposed
Bylaws, you mean?
bylaws. So one of them,
Does Holly have these?
she does, but it
Okay.
was not,
I don't have
there was not added language.
for her drafted,
Right.
but I have the concepts of
Okay,
what she
good.
would
I just
like
want to make sure
be
Holly has it.
No, she
Okay.
does have it, but I just wanted
Sure.
to clarify why my reasoning behind it. I think one of them is related to agenda items, and I think that language was in the past in the bylaws, but it's no longer. I would love if we can adapt that language back to the bylaws to allow 3 or more members to, if they wanted an item to be added to the agenda, to have that flexibility and option. And there could be a clause to it if you feel it's deemed appropriate, because I know there has been an item that we've requested on multiple times that was not added to the agenda, and we feel it's important. So that's my reasoning and for that item to be added back. And I know that one of the proposed changes is that we only vote once every 2 years for officers, but I think in terms of I think it will be a good practice to have at least some feedback on how the years are going with the current officers. So that's, I don't know, that's one of the changes that I requested possible. And given my past experience with resolution, I feel we should probably have a clear guidance on how to come upon resolution, so there's not any issues in the future. And another one component item, as I've clearly mentioned it today, is the more transparency and clearing the process of how we appoint board members and staff to committees, which you will address on next month, I believe. That was one. And also another item that I've felt it's really important, especially giving right now, I can give you a clear example, is the LPPF model. I would love for us to have more information at a timely manner, to not feel that we're rushed into making action. So at least to give us ample time to provide, because I'm still trying to digest from the workshop, and I trust the staff and the intention behind it. I did my due diligence to understand it. But in the future, if we come across really major items that will impact the way Central Health does business, I ask we get more information at an earlier time. So those were the proposals that I've asked if we can consider it, and I hope we can. Thank you.
I'll say, I think that all those are reasonable.
Again,
So those are the ones that I've asked for.
Okay, great.
And so what I would do when we decide what the members of the ad hoc committee are, or who they are, I will send anything that I've gotten from other board members to the members of that committee, so everyone can see what's already been sent to me and can further discuss those things.
Manager Valdez.
I just want to assure Manager Moreau that Sherry has heard me make these very suggestions prior to getting on the board. And so I promise you that I would be an advocate for such language, just wanting to let you know.
I think it serves us all good.
Yes.
Yes, I would ask that we give some time frame in which the committee to report back, as opposed to leave it open-ended.
Maybe a month? 2?
My suggestion would be, because schedules are going to have to be coordinated, and we don't want to try to do that now, to get some kind of scheduling polling done, and then our chairman or
His time. Also.
or Mr. Giesland can look at that, and our chairman can then set up a time. But it's kind of hard to do now since we don't know meetings.
But could we not say that this needs to be done within 60 days? As opposed to saying we'll get together and then come up with a date, and then that may be 90 days. So I'm just saying, give direction to the ad hoc committee in terms of expectations.
So, I think 60 days would be reasonable. I would not let it get any further closer to the budget
Yes,
process.
I agree.
That's right.
It already is the 60-day
agree.
mark. However, again, you don't have to report the whole thing
No.
out at once. You do need to report out in batches, those of which are dependent upon each other.
Consensus.
But if you needed a little bit more time, like any committee can go back to the board, and the
Right.
chair can intercede and say, or ask, I need another 20 days on this one particular group, or this one particular one, it's gonna take us longer. So I think, you've got some flexibility on that.
Yeah.
But I think 60 days.
Yeah, I think that's fine.
All right, so what I'm hearing is I'd like to appoint Manager Valdez, Manager Jones, Manager Greenberg, myself to this committee. I don't want to chair this committee. So who would like to chair this committee?
I would suggest Manager Greenberg.
Manager Greenberg, would you be willing to take the chair of this committee?
Certainly.
Sorry, Sherry.
Yeah.
All right, Sherry.
I was going to say you. Okay.
You know the legislative.
Oh, you want me to be a chair or something? Okay, yay.
You want to chair?
I don't, it doesn't matter to me, but I am interested in the issues.
I'd like Cynthia Devala to be chair. I'll be happy to appoint her. All right,
Okay.
so I'm going to go ahead and appoint Manager Valdez as the chair And Manager Valdez, Jones, Greenberg, and Zamora as the members. Do we need to vote or anything?
So all we need under the current bylaws is actually approval of the members of the ad hoc committee. So there'll be a motion to approve the appointment of the 4 people just mentioned to the ad hoc, do you want to call it bylaws committee?
That's original.
It's really original.
Yeah, love it.
I move that we approve the members outlined by our chair to the bylaws ad hoc subcommittee.
I'll second that.
Okay.
All right, there's a motion by Manager Bell, seconded by Manager Musaitif. Any discussion?
I have one last comment, and going back to the section 7.34 on 21 under the real estate committee, and I know now we're going through an ad hoc committee to make proposed changes to the amended bylaws. Would this impact any future work for the downtown campus committee if we postpone adopting this new language? That's probably my question.
I'm sorry, the section you were referencing again, 7.
Page 129.
Got it.
7.3.
Sorry, I didn't see that
No,
straight.
because we still, no, it would not, because we still have a
Okay,
functioning
that's-
committee to bring it back to.
Okay, that's all. Thank you.
All right, take a
All
vote.
right, so let's take a motion. Let's vote. All in favor, say aye. Aye. All against, no, no. Any abstentions? All, motion passes. Thank you all.
Thank you, members.
All right, agenda item 3, discuss and take appropriate action on proposed amendments to the Sendero Health Plans, Inc. bylaws. Dr. Bell.
Will you entertain a motion? Or do we have to hear it?
You have to
We're
hear
doing the
it.
presentation. Okay.
I would like to put that first.
Ditto. I'm going to say Dr. Bell.
In just a little bit. I won't be long, believe me. I had presented to you the Sendero bylaws at a previous meeting and talked to you about the reasons why we needed to clarify many of the items in the bylaws. They were confusing. They were titles that didn't make sense for the organization. And I don't think, after reading them and trying to understand them, that we were actually following them as well as we could. So clarifying, being able to bring it up to date so that it relates well to the organizational structure of Sendero is what we attempted to do. You've had time to review those. There have been no suggested changes by either the Sendero board, and I have not heard of any major concerns from any of the members here. So I would like to ask for a motion to be able to approve.
I'll
Well, okay, it's the chair.
Manager Valdez.
Yes, I'd like to move that we approve the proposed amendments to the Sendero Health Plan bylaws.
Second.
Second.
We have a motion on the floor by Manager Valdez, seconded by Manager Greenberg. Any discussion? Seeing none, all in favor say aye.
Aye.
All against say no. Any abstentions? Motion passes. Thank you, managers. All right. Agenda item 4, discuss and take appropriate action on the employment contract between Central Health and the President and CEO of Sendero Health Plans, Inc. Dr. Bell.
Yes, at our last budget and finance meeting, I passed out a copy of the contract for the CEO of Sendero for your review. This contract, again, was developed by the Sendero board. After that draft was done, we sent it to legal. Legal reviewed it, and then I worked with Mike and Susan to be able to make sure that it adhered to the policies that are already contained in Central Health and that it wasn't divergent from any of the major policies that are already in place. We sat down and we negotiated this contract with Wes and took his input and attempted to address, we addressed his issues and gave you the draft for review. I have not heard from any member, well, I take that back. I did hear from one member with regard to additions that they suggested. We had a discussion with regard to whether those conditions should be added to the contract or whether they were contained in policies here within Central Health and within Sendero and not necessarily have to be restated in the contract. And so that seemed to address that member's issues. And I, again, haven't heard any others. So if there are no issues, we can have a motion and discuss.
Manager Walden.
I'd like to move that the board approve the terms of an employment contract between Central Health and the president and CEO of Sendero Health Plans.
Do we hear a second?
Second.
Okay. I have a motion on the floor by Manager Valdez, seconded by Manager Musaitif. Any discussion?
Chair, I would like to mention something else, that approval of these contracts has actually been given to Mike because of concerns that were voiced to me as the chair of the Sendero Board. I felt it appropriate to bring the contract to you as a board, and Mike agreed for review and approval. So that's why you're doing this. You don't have to, unless there is issues that you discuss with Mike, approve other CEO contracts.
Any questions? Manager Valdez. Manager Jones.
Could you say that just one more time, because I'm concerned about precedent in terms of what your role with regards to Sendero and any other board members or even staff, I guess, with regards to any other enterprise organization. So could you walk through that just one more time?
What I just said?
Yeah.
Okay. In the Sendero bylaws, the member, who's Central Health, not the Sendero board, allows certain duties that only the member can perform, meaning the board.
The Sendero board.
No, the Central
The
Health.
Central Health Board, okay.
Okay. And so within those, and I think it's section 1 of the Sendero bylaws that outlines what Central Health can do and what it can delegate. Of those, there are a number that they delegate to the CEO. And approval of executive contracts of our affiliate, well, of Sendero, can't be of our affiliates because it's only in the Sendero bylaws, okay, is a function delegated to Mike. Okay.
I follow that. My question though goes, and I don't know if it's appropriate to ask or not, but is this consistent with what we do with any other our enterprise?
I don't know that.
With other entities within the enterprise, such as the CCC, Sendero Community Care, there are typically what you see members' rights. So in this instance, with respect to Sendero, we are the member. We're the sole member because we're the sole contributing capital source. And so you do have clauses like this. They're each different because each entity is different, but as a matter of course, you have members' reserved rights.
So it's consistent with the philosophy of
Yes,
dealing with
that's a
each
better way
one
to put it.
individually.
Yes, just not the specifics.
Yeah, okay, all right, thanks, that answers that.
Manager Walden.
Just wanted to clarify. So that's why when we saw all the bylaws side by side, when you provided us that information, that was with all the other, because the other entities, because they do have members outlined or specified in their bylaws, and not Central Health because we're not the members, we're the board. With respect to the approval of things for the enterprise.
The term member in the
I think it was like number
corporate-
3 or 4 when she provided side by side.
Just be a little careful because I understand why that question was asked specifically about, is this a good precedent for us to be, as a board, approving a contract that Mike, under the bylaws, has authority to do without your approval? So that was a great question, and I appreciate everyone acknowledging I sent things out, but we've got to get back to the, back to the agenda item of the actual contract.
Okay. Thank you, Council.
I'm done.
Any other questions? Seeing none, we have a motion on the floor by Manager Valdez, seconded by Manager Lucitif. All in favor say aye.
Aye.
I'm gonna say no. Any abstentions? Motion passes. All right. Agenda number 5, discuss and take appropriate action on the 1115 Medicaid waiver, delivery system reform, incentive payment, district projects, Community Care Collaborative, including healthcare delivery arrangements, and other interrelated community partnerships. Mr. Knodel and Ms. Rowley. Oh, this is executive, sorry.
Yeah.
All right, sorry about
Executive
that. I announce the board is convening in closed session to discuss agenda item 5 under section 551.085 of the Texas Government Code governing board of certain providers of healthcare services.
died this year.
All right, we're back on.
It's 7:12, we're coming out of the executive session, no action will be necessary. Agenda item 6, discuss and take appropriate action on an update regarding Sendero Health Fund, Inc., including the effect of legislative and regulatory actions. Wes, please introduce your guest.
Yes, Dr. So first off, thanks to the board, and we're happy to do this in open session. We will be discussing nothing really too proprietary, too competitive today. So we're happy to have some open discussions. Most importantly, I'd like to announce and introduce our new Chief Medical Officer, Dr. Robert Allison. Thank you. Thank you. And Dr. Allison has a resume, definitely. And a long career starting at the CDC, then to the World Health Organization, and then to NIH, where he was most recently Section Chief in Infectious Diseases, which is where we kind of first made contact through him, through some of our public health research projects that a few years later kind of led to him, well, I'll let him tell the story. But so what we'll do for the agenda today is, I do have 8 slides. I am planning on only taking 30 minutes. I'm happy to go as long as you feel necessary. So for tonight, I'll let Dr. Allison talk a little bit about his impressions on Sendero, and maybe just talk a little bit about the chat membership. Then additionally, I'll be talking, I've got 3 or 4 slides on the Travis County and out-of-county membership of Sendero. We can have a good discussion about that. And then also at the last minute, I added a slide about the recent legal and political discussions on ACA, so we'll finish with that. So I think with that, I'll let Dr. Allison, definitely, suggestions.
Ask one question before.
Yeah.
Directed to Dr. Allison, thank you.
Sure.
I have one simple question. Why did you want to join Sendero?
Sure. We're skipping to the second part of my talking points here, which Wes created, so I stayed on point, and I didn't go on and lecture forever and ever and ever. For example, if you saw my CV or the press release, that was really, really kind of you. I've worked in a number of agencies, both local in the U.S. and internationally in public health, and I met, I came upon Sendero because I did hepatitis C work really globally, but then most recently at NIH, at the NIH. And so I've been helping them with a hepatitis C project, a continuum of care project here already. So that's how I learned of them. I was, frankly, I really wanted to get back into field public health, where real public health is done. I love the NIH, but really miss kind of touching the community, like I did with the polio program in India and Southeast Asia. I did more health policy work in the Middle East and North Africa, but where you can really see, you do something and you can see the change, the improvement, the impact pretty quickly. It was Wes or somebody I worked with on the hepatitis C component who said, hey, that's great, Rob. You want to go overseas and get back into field public health and get back to kind of serving the underserved. Said, I think Wes said, there are poor people in the U.S. too.
Yeah.
There are poor people in the Austin area who would really benefit from your help and your enthusiasm and your background. And I looked, I started really understanding, researching more, learning more about Sendero, about Central Health and Sendero, and understanding it's a nonprofit. It's taxpayer funded, so we're accountable to the taxpayers of this area. But I think, and as important, it's community based. So it's very similar. It's exactly what I wanted to do, what I have done before overseas. But it's here, and this is also a great place to live. I think those are the main. Those are the main reasons. I appreciate the question too.
Well, we're lucky to have you. Thank you.
Thank you. I really appreciate it. Well, I think that's it for me. That's not true. But I mean, I have to say, I'm very thrilled to be here. I'm really thrilled to be part of the Central Health and Sendero team, and feel very fortunate to support your mission. So I'd like to take a moment to just give an overview of our strategy. I know you know I've only come on board a few weeks, so be a little easy on me. But as soon as I arrived, I feel like I've been able to hit the ground running. We have the slide up. Great. Okay, the laser pointer's not going to work behind me, and everybody's looking behind me, so I'll skip the laser pointer. So here at Sendero, our strategy for improving population health aligns with the Institute for Healthcare Improvement's triple aim. And essentially the idea is to improve the health of the population you serve, not only by providing health care, but by addressing social determinants of health, to improve the patient's experience of care, and I think, as we well know, when patients are engaged, it's much more likely that the outcomes of care will be better. And then thirdly, to reduce the per capita cost. And this doesn't mean just denying health services to save money, but really to ensure appropriate care is provided. I don't think any of us can argue with that. And I think that's a major advantage of managed care and a managed care plan like Sendero. And to note, all three of these components, many plans try to do one or the other, but it's very clear from IHI that all of these components need to be done, can and should be done at the same time. So that's, of course, part of our strategy. So how are we doing this? This is more high level with a few examples. So the first, to improve quality of health in our population, we measure that by standardized HEDIS measures. We built a health services research team that analyzes our data, and they help us develop interventions that are, which is great about a community-based health plan, that are tailored to the population that we serve. Our intent with this is to share our experiences, build collaborations, and build best practices in our community. The second, to improve patient experience, what we use is standardized CAHPS member satisfaction survey. We use those data to identify the strengths of the plan, but also to identify gaps where we can improve. And as an example, to engage our members in their communities and in their homes, I think we provide a personalized experience with our community health workers, really a great value to our plan. While improving population health and patient experience, we all understand there aren't unlimited resources. This is always the uncomfortable talk, but we know that this is reality here. But I would say, so we deploy utilization management strategies, but essentially to help whether the right care is delivered at the right time. And again, I don't think that's controversial. That we can all agree on. And so we're going to go back to Wes for a moment. He's going to give a general ACA update, kind of based on the flow of the slide, and then we'll come back to me, and I'll give a CHAP members update.
So in ACA, just to refresh everybody's memory, we're currently at about 14,000 members. We expect that to average about 12,000 members per month over this year. That's in line with our projections that have been presented and with the budget. Slightly less than 60% of our premiums are coming from APTC. This is slightly less than prior years, which is kind of interesting. We would have thought that people without subsidies would have dropped out, but we actually, not as much as we still have, we went the other way. We picked up more people who don't get subsidies, showing we're offering some kind of value. We have 25% more bronze members than last year, which is in line with our projections. So the bronze members have two benefits for us. On the business side, I guess the easiest way to think of it is that these people are healthier, they require less care. That makes the financials a little bit more stable and additionally frees up valuable staff time and resources to focus on the CHAP program, which is our main objective, for this year. Additionally, you may have heard a little bit in the news about the cost-sharing reimbursement lawsuits that were recently found in favor for some of the costs or some of the class action lawsuits. We did not join the first round. Those lawsuits were for 2017. In 2017, we really had no damages from the cost-sharing non-payment by the administration. However, the lawsuit ended up being determined for both 17, and since it determined that as precedent, it applies to 2018. For 2018, real roughly, we probably have somewhere in the neighborhood of 6 to 8 million in damages that we can claim. So we will likely be claiming that, joining one of the larger lawsuits that's was found in favor of one of our sister community plans. So we'll have more on that as that develops. And I think later on we'll come back to it. We'll save it for the end. We'll have kind of more the more open political discussion about ACA and recent events. But I asked Dr. Allison, which I appreciate. It's first time in. He's only been here 2 weeks, so I kind of he definitely had a whirlwind first few weeks. But I asked him if he wouldn't mind just sharing some impressions or just like a few basics on the CHAP program and how it's going.
So where are we with the Central Health Premium Assistance Expansion Program, the CHAP program, our 200 plus? I had to say that to see if I could say that. But now I'll always use the acronym CHAP. So how are we doing with our 200 plus CHAP members in Sendero? Well, so all CHAP members are now working with an assigned community health worker. All CHAP members have already had a health risk assessment. We've developed and deployed a comprehensive health evaluation tool. CHAP members have completed or were assigned 50 plus inpatient stays thus far, at least 125 primary care physician visits, and over 50 home visits so far with nurse practitioners. We've had positive, and I've only been here for a couple of weeks, but since I've been here, we've had great positive feedback from both members and staff. Also in my short time here, I've seen already more than a dozen cases where members, these patients were able to get urgently needed care where they, appropriate care where and when they had to get it. So that, back to Wes.
Yeah, and I can add on that. So with the CHAP members, would say, so the inpatient stay, in case you caught that, already 50 of them have required inpatient stays, which we're happy to be able to coordinate and get them in. So it kind of speaks to the,
Need.
kind of the need or the demand for that. Along with that, the PCP evaluations. What we did, so if you remember from the discussions, there's, kind of two sets of correlated goals, and one is just the delivery of care. So that was the idea behind the short HRA, to make sure, right from the get-go in the handoff, we were addressing the urgent care needs. We had that going. The second goal is that as quickly as possible, we wanted to be able to kind of assess from a ACA and CMS standpoint, how sick these people would be. So for that, we had the more comprehensive health evaluation tool, which you caught at the end, yeah. So we developed that pretty quickly on the fly, like 4 or 5 weeks ago, and it's pretty awesome. It's a nice. So the idea is that, when you think about it, when you go to a PCP, even for yourself, when you go back, it's pretty cursory, pretty standard, sorts like that. If you've already been seeing the doctor, it'll be even shorter. In this case, what we were really looking for was a top-to-bottom eval. So we got nurse practitioners to go out to kind of I don't want to say reluctant, but there were a lot of members who could not get to a physician. There were a lot of physicians who we did not want to ask to take the time because it takes a few hours to do a full eval. We got a nurse practitioner group, put the eval together, and they've already made 50 home visits to these members. Each visit is at least, close to 2 hours. There's a 15-page eval that includes everything. We included behavioral health, social determinants of health, like a great deal of information. It's been extremely helpful. And a list of all their diagnosis, medication, meds reconciliation. So we had a great deal to work with. We're happy about that. We're kind of carrying that forward. We're going to keep going as long as we can with those, get as many people as we can to give us full. So in short, we're pretty comfortable that we'll have, not only a firm grip on people, but a pretty good grip on the, we'll say the reimbursement aspect of the program. So we're happy about that. And Dr. Allison jumped in just in time to help. I mean, as he said to me, he's extremely comfortable with case management, and in the clinical aspects of care. So it's population health, but for a lot of what he's doing, it touched on that case management for sick people. And so he's very comfortable jumping in on that, which we're very thankful for. Any quick questions on chat?
Oh, thank you. So you alluded to screening for social determinants of health.
Yes.
Can you elaborate more? And are you
Definitely.
connecting the resources, and how are you screening them? What tool are you using?
So the original was I should have brought one. It's pretty nice. We could have passed it around, but. So what we did was kind of take 3 or 4 standard tools that are out in the community. It's a combination of some of the ones from like People's Community Clinic and I'm going to say it wrong. I don't know if we quoted it in here. But we took 2 or 3 of the standardized tools and focused on the core concept, because the idea was more, there was already a 12-page physical eval. So all we wanted to do with the SDOH and to some degree the behavioral health was kind of set up a trigger or a flag for future follow-up. So it's kind of acknowledging, look, the nurse practitioner already had her hands full focusing on the physical side. All we really needed from her was just some way to flag a member to say, hey, whether it's housing, food insecurity, transportation, just safety of the home situation, they can flag it so that the CHW can follow up, hook them up with behavioral health.
Resources.
Our behavioral health people, we already have, social work, and I'm skipping one, the social worker and a behavioral health specialist. We have a BH screening portion of the assessment too. On the BH side, I know, that's why that's in my head, we were just talking about this an hour or so ago. We've got over 50 people from CHAP and behavioral case management already. And on the social determinant side, likewise, CHW is the primary, but I forget, we have 2 social workers and they're working full-time for CHAP. So that's the easiest way to say it.
How are you going to be?
That's kind of,
So it'll be in the future if you can just
Share
try
more?
to
Definitely.
show us more on how you're tracking it,
Sure,
and in
yeah.
terms of
Yeah, because this is good.
connecting them. Are you just flagging them and follow up in terms? I
No,
just
wait,
wanted to see the
definitely.
outcomes.
Sure, definitely.
Thank you.
Yeah. And that was the idea, was that this gives us a good baseline. It's like where the people are. I'm trying to think if I want to say any, no surprises, definitely a lot of need. I think
And the People's Community Clinic tool, I believe they formed it. They actually had a grant from Episcopal Health Foundation that helped them to draft this tool.
Yeah, that is nice. I know we can go to Episcopal and ask for money. I didn't think of that, but
That's right.
but
Go to Lutherans also.
definitely- No, but it's definitely the idea that there are a lot of good tools out there.
But that one
For
was
us.
really thoroughly vetted and been involved in it in some way. Thank you.
So the last point on the discussion was the out-of-county, Travis and out-of-county business discussion. We've got 4 slides. I'll try and walk you through a quick summary and then 3 slides on each of the main pieces. So for this analysis, we looked at maybe 3 different main pieces, and the first piece was, let's just go back and look at the actual distribution of members and premiums and claims. The second piece was, let's go look back how that allocation or distribution of membership, could be correlated to the allocation of funds that we've expended over the year. And then the third part was a real straight, based on the prior 2 pieces, let's go back to the P&Ls and evaluate how it would look, for a prior year and a future year, what the effects would be. So I'm on page 6. Basically, we're in the 8-county Travis service delivery area. That's a result of us starting off in Medicaid, where there's a
It's 5.
defined service area. Is it a 5?
Yes, sir.
Okay, yeah, sorry. I try to get bifocals. Because the Medicaid service area for Travis is considered the 8-county catchment area. That's where Sendero started. That was either all or none in that case. In 2014, when we went into Marketplace, just for the sake of economics, we stayed with the same system, meaning the same network, the same providers. Of course, the advantage being that the more members and the more area you cover, the more attractive you are to a provider network to work with. On average, the marketplace, roughly about 38% of Sendero's marketplace membership has resided outside of Travis. This is more or less in line with most general population estimates and distributions in the region. And we'll come back and talk a little bit more about those. Based on that, after we do some analysis, we'll walk through it, but we end up thinking, with an estimate of about 24 million of the 108 million that's been funded to Sendero since 2011. So of the 108 we received today, that includes, everything through today, 24 million, we could say, oh yeah, fairly we can attribute that to care for membership outside of Travis. From there, you say, well, what would have happened if you didn't have it? And our analysis indicates that without the additional membership, administrative costs for the Travis membership would have been significantly higher. This leads us to the P&L, or kind of pro forma recalculations. So we took our actual pro forma from 2018 and reworked it as if we had only participated in Travis County, so excluded the other counties. And in that case, we still would have had significant losses for this year, for that year. However, those losses would have been reduced by about $2.6 million. Likewise, for 2019 going forward, we looked at it and said, well, what if we had only participated in Travis County? And in this case, it was a more drastic effect because of our smaller membership. We would have decreased projected income by $4.6 million. So you don't have to memorize any of that, but I'm just trying to give you the high level, and now we'll walk through each of those pieces individually and then try and tie it back together. So ACA distribution by county. Slide 6, who's got it? From 2014, when we started in the ACA through today, Travis County has represented 62%, 38% outside. Of that, of course, Williamson is the biggest, 24%. And somewhat, it may be surprising to you that the distribution is relatively consistent no matter what you use to slice up our business, our book of business, whether we look at claims cost, risk adjustment, premium subsidies, premiums, it all indicates that the populations are similar across the counties. This was kind of useful to us just to help us think about whether we were unfairly, disadvantaged by any particular county, but not in a material way. And below that table at the bottom just shows the actual final distribution of risk claims, risk adjustment, and premiums for 2017. And basically it's in line with what you're saying. So it's like basically saying that Travis County is 62% of membership. In 2017 it was actually 63% of total membership. Claims and risk adjustment dollars, allocated to the members. 62% of the claims and risk adjustment dollars went to those members. On the premium subsidies, the same proportion, and the premium, same proportion. So it kind of tells us that when we're thinking about in and out of Travis County, we are not really concerned about adverse effects from the outside counties. We can just look more to general distribution to figure out what the effect would have been on our costs. Next.
Oh, yeah. Just a quick question, so that you grasp. You said Travis County. How do you ascertain citizens in Williamson County that lives in the city of Austin? Are you sure that you're separating those out as Travis County residents?
We kind of use the official address of record. So this is with CMS, and they bounce their records off of, the federal records. So I guess the way to say it is, we benefit and maybe suffer from the same issues that any federal, that the regular federalists. So it's like, yes, there are probably cases where people list a street address that isn't, but.
I was just inquiring in terms of.
It's a good question because that comes up a lot because it is, it's just because of the proximity.
Overlapping.
And the
Well,
overlap.
But we are set up to serve Travis County. So yes, we could have people who are in the city of Austin but live in Williamson County, but we are set up to serve those residents of Austin who are in Travis County.
or Pflugerville that live in
Or
Travis
Pflugerville
County.
who live in Travis County, exactly. Or
Right,
by
but I'm just-
county line, not by city lines.
Right, no, I just want to make
Yeah.
sure that we're making that we're disaggregating
Yeah, no, I
those who
understand.
are
Oh, yeah.
living in
Yeah.
Travis County from Williamson County in the city of Austin.
Right,
So
no, I agree.
It's the 62% Travis, everything else Williamson and the surrounding counties. So then we take that distribution and say, okay, let's go back and look at our funding, you know, the resources that have been expended, and allocate it back out to see what it looks like. So since 2011, as we mentioned, we've gotten 108 million. We still have 13 million on our current balance sheet, surplus about 13 million of that 108, meaning that 95 million was expended over the 7 years since we started. Of the 95 million, 32.4 million was for the Star and Chip service area. So in this case, those funds were expended, but there's really no way to disaggregate them because Medicaid is all or none. You know, so that's back then that was the decision, and there was no other way to do it. Of the 95, to take away the 32, you've got 62 million that's left that was used, you know, for ACA overall across all the counties. And then we said since Travis is 62% of ACA, no matter how we looked at it, membership financials, this suggests that the remaining 38%, or in this case, 23.7 million, you know, 38% of the 62 million ACA was used or allocated outside of Travis. What did Sendero get for that 23 million? It's like, well, the 23 million supported healthcare coverage outside of Travis. That brought down an additional 147 million in premiums over the years, which included 26 of that 147, 26.5 million was towards administrative costs. You know, so it's like that was funding that we would not have had, and those costs would have fallen wholly on, mostly on Travis. That leads us to the next question of like, well, what would those costs have been? You know, what would the effect have been if we did not? So that's where we went to the P&Ls. It's the last slide. It's slide 8. P&L effects, where we went back with the, to our P&Ls and just separated it out and reran it as if we were just limited to Travis. A lot of people spent a fair amount of time on this, talking about it up until the bitter end, like 10 minutes ago, just trying to make sure it makes sense, because it is kind of interesting and maybe not quite intuitive. We took the P&Ls and variables we adjusted included reducing ACA membership by 40% to say, hey, let's pretend we're not serving anything outside of Travis County, with corresponding reductions in total premiums, the risk adjustment, adjusted medical expenses, overhead costs, TPA, and for the salaries, we went back at staffing and kind of took the high end of possible cuts that we would be able to make, you know, because you think a lot of the departments, network finance, things like that, it doesn't matter how many members you have, you still need people running your network, you still need people in finance. So for most of the departments, it wasn't significant. Health services, you can make significant cuts, a little edgy, so we said maybe $1 million reducing salaries. Under this scenario, when we exclude the surrounding counties, the net effect was that we reduced the net loss for 2018 by $2.8 million. Depends on how you want to look at this. You know, you could say that's 1.5% of the premiums. You could say it was 12% of the, you know, of the loss for 2018. But in effect, it was a very not negligible. It's $2.8 million, but nowhere near the $20 million that had been invested. You know, or even if you said $5 million for that year. If we look at 2019, reduces net income for 2019 by 4.6 million, that is significant. So what this really drove home was that because on a year-over-year basis, you know, there's two rules in insurance. One is that you're spreading your fixed costs, and the larger base you can spread it over, the lower those costs are for everybody. And the second is this idea that, you know, especially this year, going forward, things like that, you are priced, basically we're nonprofit, we're priced to break even. So if you exclude members, you just in effect like start losing money. So when the conclusions, we basically say, limiting to Travis County is likely to materially increase our administrative costs, leading to significantly higher premiums and or reduced income for Travis, which is what you're trying to protect, so that's the counterintuitive part. You say, hey, you're placing an unfair burden on Travis because they're covering costs for other counties. It's like, yeah, but remember those other counties are also bringing down funding and premium. And in this case, we'll just say it's basically a wash to some degree. And if you say, well, then can you raise premiums outside of Travis? It'd be the same as raising it within Travis. The way the pricing works, we talk about this a lot, on the ACA, is that when you raise premiums in insurance, if you raise premiums to make more money, it's usually counterproductive because you end up with fewer members. Like in a competitive market, raising premiums does not get you more money, in a one-to-one way or anything like that. So, in effect, we would be hard pressed. If the request was to say, can you present a business plan that is meaningfully better or something by excluding the other counties, and between me and the actuaries and even TDI, it would be I don't want to speak for anybody else, but it's like, ooh, that would be a hard sell because there'd be no clear benefit, kind of say. And with that, I'd say, I don't know, maybe we'll ask if Betty wants to say anything first, and then we can go around and discuss, because this was a lot, so.
I saw that the members had some questions go up, but there's a summary point here that I think is important for you to understand. But Wes, if you could, I'm going to say something for you to react to, and tell me if I'm capturing this correctly. Now, Mr. Chairman, members. So when I do the math and I look at outside of Travis County versus in Travis County, outside of Travis County, if I take the premiums to what your claims and risk adjustment costs are, it's 95 cents. Okay, so another way to think.
I'm sorry, say that again?
95%. All right, so it's 95 cents. So you're.
If you look at you say 27. Yeah,
it's a crude loss ratio basically. Whereas if you look at the Travis County, it's 97%. And so, if I understand you correctly, what you're saying is you have this book of business over here that is, per percentage, a little bit more expensive than what the Travis County book is. But if you didn't have that, it would cause cash flow issues.
Even think of those numbers you just said, the 95, 97, didn't matter. You were still benefiting by a few percent. I mean, so it's like when you look at our 2019 or, where we stand today or projected for next year, you price at 80% and everything extra kind of flows to you. So with your numbers, you're like, well, yeah, but that's so small. What's the point? It's like, well, it wasn't 90. The plan wasn't to do 95%. This is the way it turned out because the risk order was canceled. Things like that. This kind of leads to the question: it's like, well, can you make up for that somehow? And that's where it's like, not really. Like, there's no easy way to say. If you go to the actuaries and say, hey, just to be safe, I want to raise premiums 10% outside of Travis. It's a totally defensible politically story, but to be honest, it's kind of hard to justify it. And I'm just going to speak from the insurance company point of view, because every extra member, we're already a small plan. Every extra member in this case gave us the necessary cash flow to kind of support the chat members. Mm-hmm. So if I just said, in addition to the admin, you say, well, my admin costs for Travis are higher. That's okay though. Then it's like, all right, then that's fine. Just do it that way. I'm like, well, okay. You went up, but then additionally, you kind of lost that risk adjustment funding
But
for
for-
CAP members. I don't know if that,
But for purposes of understanding, it's not that the Out of Travis County book is a profitable book.
say it again, it's not that it's,
The outside Travis County book of business is not a profitable book.
well, none of our book is profitable.
I understand that,
Neither
but if
side.
you were to segment this. then-
Yes.
Okay, all right. Thank you, Mr. Chairman, for allowing me.
Might as well, that's a question.
I did. Well, it was first as a statement, then it's a question. I guess it's both. So with respect to value, the added value community offerings that you present to those in Travis County as opposed to those in other counties, that's been one of the reasons that you have remained a steady community partner and advocate because of those outside benefits that are brought to the table for the residents of Travis County. Is that correct?
Well, my interpretation would be, oh, yes, because
For me, it is, as a community member who can benefit from some of these things.
I mean, even the simple one would be the provider network.
In the generic form,
You know,
yeah.
it's like it benefits everybody to have a broader provider network.
That's right.
You know, which you get by having more.
And that's only those are really, community benefits, the added value component is only really available to those that live within Travis County, not necessarily to those that live in any other county.
Well, especially this year because the
That's right.
value added is CHAP. And it's
That's right. Well, and that's in addition to what has been offered historically. So if we did increase that for Travis County, then what we would be able to see, hopefully, is a greater rate of return on the bottom line for Sendero.
Yeah, that's kind of the challenge, is that any business plan you present is stronger by adding the surrounding counties. That's the way to say it.
Yeah.
I'm sorry.
Manager Greenberg?
So, I understand fixed costs and variable costs. And part of what you're speaking to here is fixed costs. There are certain fixed costs for running any enterprise, whether it's a 7-Eleven, or it is Central Health, or it is Sendero. And so that's really part of what you're talking about here, is that there are certain fixed costs administratively that would not go away. There are other costs that are variable costs for people providing health care that would go away if you decrease, because you would cut that. I also understand that what you're saying is more members is better. And so it doesn't really matter whether those members are inside Travis County or outside. You're just saying more is better. And that's what the numbers that you're giving me are showing. It's just that, yes, if you have a larger number, you're better off. But I think we have to set that aside from Travis County or not, okay? Because if you increased your membership within Travis County, it would have the same benefit, right? Yes.
Member anywhere, sure.
Yeah, more members is better. That's really what we're getting to here, at least from this math. And I'll talk to you offline because I'm going to need to see
No, I know there's a lot.
underlying numbers, because what you presented here is, for instance, reduces net loss for 2018 by 2.8 million. Okay, so having those out-of-county members, you're saying reduce the net loss by 20, so we would have saved money by having a lower loss in 2018. But in 2019, you're saying that net income would be down. Those are big swings, and I need to see the numbers behind them. So I will get with you offline, because that's obviously not something we're going to go through here, but those are big swings.
It's counterintuitive.
Well, it's not that it's counterintuitive, but they're big swings, and I also need to see going forward beyond that. 2 years does not make a trend. Let me put you that way. I'd like to see 3 years historical. I'd like to see going forward, and I need to see the numbers behind that. So we've got fixed costs and variable costs. We've got what you're saying, which is more members, at least from what you're saying here, is better. It doesn't matter where they live, really.
Yes.
And so I understand all that, but there's another issue here too, and it's aside from, and I also understand pricing, that yes, you've got your curves here, right? And at some point, if you're increasing your price so much, right, then you're going to lower your revenue because fewer people. In other words, there's a break-even point, is what you're talking about. And so where is that break-even point? Where is the point in your pricing if you were to increase prices for those outside of Travis County, that instead of increasing revenue by increasing the pricing, you would either break even or even lower the revenue? So that's something else to examine. And then the last thing is that there is a separate issue from all of this that is separate from and apart from premiums and where people are coming from as far as your more is better, no matter where they live, and this whole discussion that we were just having of premiums, and that is equity as far as taxpayers, right? And so something that I think that we all need to keep in mind at this point going forward is that if there are services being provided and Travis County tax dollars are going to provide those services to people who do not reside in Travis County, aside from premiums, okay? There was equity put in here by Central Health, which is Travis County taxpayers, then there needs to be a way for those taxpayers to put their share into the kitty. And that's not what I have seen here from, not premiums, I'm not talking premiums, I'm talking the capital, the equity, that went in.
I saw Manager Masaito first, then Manager Jones, and Manager Valdez.
Thank you. I agree with you, Manager Greenberg. Another thing that I really want to highlight, the transparency piece, and our Travis County residents need to know about our health plan and what it provides for out-of-county residents. So I think that piece is missing, and I call for more transparency for all to understand where the money is going.
Manager Jones?
I agree with what Vice Chair Greenberg said, as well as Manager Masaito. I guess my question, though, is that as the population of Travis County is forced out into the suburban counties, many of those are the counties you've outlined here, I think that we do need to address how does those counties, goes back to your question, account for their support of this initiative, of this effort. The question is, are they opposed to it? Has it been presented to them? The changing demographics of the elected officials in those counties are changing too. So I think the opportunity to encourage you to try and do more outreach to get them to buy into this will go a long ways to satisfying their needs, but also the taxpayers of Travis County as well.
Thank you, Manager Valdez.
And mine was when you, with respect to the term equity, knowing that the majority of the people that are benefiting from Sendero's comprehensive continuum of care are people of color, as opposed to not, and the fact that they're participating in a comprehensive continuum of care services delivery model, as opposed to maybe not having the ability to, and I'm assuming because of the previous that we had, the subsidies, et cetera, paid for. Now we don't. But the people who bought into it understood. I think that's one of the reasons that they have remained with Sendero, because of what they're getting access to is a big difference, even though they may be borderline and struggling with the cost. It's 1,000 times better than what they would have gotten under a MAP program. And I think that's I've heard people say that. I've heard them say that they were on MAP, but they'd rather pay a little bit extra, and participate in a Sendero comprehensive plan than they would in remaining in MAP, and then just being stuck with a siloed or dysfunctional system that we're trying to repair. So, and the majority of those people are people of color.
Manager Roller?
And I would say, to your point again, if there's a way to get other counties to be active participants in funding our model, that benefits everybody.
Right.
And I don't, especially I think Hayes and Williamson I'm not going to speak for them, but I would think that they understand that there are significant populations of their people that are being funded by Travis County taxpayer dollars. And it seems, and I think they're reasonable. I mean, these are other counties that are participating in other healthcare programs. I think it would just be a reasonable expectation that they should pay something towards it. But I also think that if we exclude them, then the costs borne by the Travis County people is probably going to be so significant that we couldn't create an appropriate pricing model for Travis County, and the program would implode. So it's kind of this balance of, you have to augment it right now because there aren't enough Travis County people to fully sustain the cost. So you have to augment it with the out of Travis County people, because otherwise the administrative burden is too high for our Travis County population to price it appropriately. Is that what I'm hearing you say, I think?
Pretty much, it's
Yeah.
public good, if you say,
It is
we're
public
just
good.
gonna try and limit it. I guess it goes back to the for me, anyways, definitely, no, community health plan, community health is number one. But in this case, specifically in service to your mission, it's this CHAP program. And the way to make that work is to have some sustainable, low-risk base. And just as you go through all those talking points, suddenly it's like, I'm not sure it's like lower risk limited to Travis. And that, that's a discussion, definitely, but it's more an actuarial. We can get other people, who are more qualified to weigh in on that. But this is just like I'm happy to have this, just definitely like a good first discussion, because it is important. And I definitely would defer. I know I've talked briefly with Jeff about, it's like I defer to Central Health in your relationships with the other county, because you guys share services a lot. So I'm more than happy to go along and discuss with other counties, like the benefits and what happened on that with Central Health.
What's that?
So I just have a request, and my request is, and staff can arrange this, to set up time to go through, not just the numbers to go through the numbers for these 2 years and preceding in future.
Manager Valdez?
And one more, with respect to the, you said here on the ACA update, 25% more bronze members in 2018, including up to 75% more or less of membership. Are those bronze members, where are they located? Are they here in Travis County? Are they not?
Same distribution.
Same distribution, okay,
So third outside.
okay, thank you.
I have two other, if I may, Mr. Chairman.
Vice Chair?
One is, what would be a plan to increase membership within Travis County? Because that is our mission, and that is where, and our tax dollars run there. So to increase membership overall, not just CHAP, but there's a balance between CHAP and our overall membership, and we won't get into that now. But to increase our numbers within Travis County, a plan for that. And two, this discussion, and the next one, this discussion with other counties.
One last comment. I just wanted to, there was a hearing on community health workers heard yesterday by Sendero, by Senator Rodriguez and Representative Ortega, that did not show any opposition. Right now, it hasn't passed, but it didn't show any opposition. So that's also a possibility of reimbursements for including them in your service delivery line that you may want to follow.
Aren't they already?
No, I know, but I'm talking about reimbursement, as opposed to you picking up the full cost.
We'll follow up on that.
Thank you. I'll send you the number.
And on that point, I would say, definitely, we're more than happy to serve more Travis residents. I want to keep in mind that, I'm still going to go back to that our primary goal is the CHAP model, because we think that's where the most value, in other words, that's where we're directly addressing things that can't be. So I think that's kind of the driver of our business plans.
Manager Bill, anything else to add?
No, sir.
Any other questions, managers? Eddie, Wes, Dr. Allison, thank you so much for coming.
There's slides left.
What's that?
Oh, yeah, we skipped the most exciting one.
The
Let's
update,
take 5 minutes. Sorry about that. How did we do?
Following you.
ACA, Marketplace, politics.
So, politics, I should almost leave like a standing quarterly slide on crazy politics recently. So, the brief kind of highlights, or the easiest way to kind of put some framework around it, is that, as has been discussed, There have been over 70 unsuccessful repeal attempts through 2018. This probably puts us in the high 80s, something like that, for ACA. And, you know, each time it's hard not to panic, and it's, you know, it kind of raises all these questions and things like that, but in the end, it's, you know, they're still dealing with changing a pretty significant healthcare reform law. So there's a lot of, it would take a lot of momentum. February 2018, Texas, you may recall, with other Republican state attorney generals, argued that the elimination of the penalty associated with non-coverage makes the rest of the law unconstitutional. Then last summer, the Justice Department came out and said that it basically agreed and would not defend the ACA. It may support continuing pre-existing protections. The Democratic AGs led by California were granted intervenor status to defend ACA, leaving it in place. In December, Texas once again agreed with the Republican AGs and struck down ACA in its entirety, which was a little bit more than any of the parties had really been looking for, but granted a stay while the case is being decided. We fast forward to today, where the Justice Department came out again, filed a brief supporting the December ruling to strike ACA in its entirety. The problem with striking ACA in its entirety, even on the Republican and conservative side, two things. One is striking a code like that in its entirety is not in line with precedent for the way laws are usually administered. On the political side, you do have the fact that ACA is the home for 20 million relatively low-income Americans with health needs, and they would be, I think that was the most recent Urban Institute estimate, that they would be uninsured. So in addition to all the many public polls that show strong support for ACA, or at least some kind of health care. So in short, they're backing themselves into a pretty sticky corner. In this case, for this current battle, you can split up into who's trying to do what, and there are those inside the current administration who strongly, openly support full ACA repeal, and those include Chief of Staff, Domestic Policy Chief, Director of Office Management and Budget, which is definitely, you know, some power and authority. However, on the flip side, those in the administration who do not support full ACA repeal includes both HHS Secretary and the new Attorney General, which is kind of surprising, but even for him, he sees no benefit in repealing the whole law. So the expectation, or just a discussion I heard, is that it will play out the way it was originally intended to play out, where it will be overturned by either one of the circuit courts, or, you know, that lawsuit would just be overturned by one of the circuit courts, or even the Supreme Court. I think the takeaway from all those successful or unsuccessful repeal attempts is that even with the repeal attempts, there was a fair amount of respect for an orderly repeal, so that even in some of the filings that wanted to repeal it, they would repeal it for next year. In other words, nobody would be left hanging. So in theory, like we talk about every year, there are milestones and commitment timelines, and usually those line up with us knowing what's going to happen for the following year. So that's as short a summary as I can make it on that one.
So, President Trump very recently has raised this again with a repeal and it appears no replace agenda.
Reflected here.
But there was no collusion.
Right. I'm not talking about that. I'm strictly talking to our agenda item, which is the ACA. I guess an issue that is out there that I don't know that anybody knows the answer to is via executive order, are there measures that President Trump could take and would take vis-a-vis the ACA, because he has recently done that with a certain wall proposal, and Congress did not have the votes to
Override the veto.
vote to do the override. So I guess we'll all just stay tuned.
Yeah, so with the executive orders, yeah, that was the hand they played. That was the hand they played last year, and the extent was he could He could mess with the
Right.
CSR, but
Yeah.
he couldn't go any further than that, so.
We'll see, yeah.
And just really, this is what really frustrates me about the unknowns of the sustainability of this program. So,
Well, you're talking about our Medicaid, Medicare, and everything.
Everything.
If you feel
Yes,
ACA,
yes.
basically, we're all
I
in it,
just
yeah.
wish I can
Yeah.
inject a syringe of empathy into every single one of them, like feel with the people and meet their needs. But anyway, we can, and I appreciate your work. Thank you.
Take it as far as we can.
All
right, thank you.
Agenda item 9, receive and discuss a report from the President and CEO on Central Health operations and current activities, including A, the fiscal year and operational priorities, B, an assessment of systems.
Wait.
What's that? Go ahead. You start?
We can actually kick these, right?
Agenda item 9, receive and discuss a report from the President and CEO on Central Health operations and current activities, including A, the fiscal year 2019 strategic work plan and operational priorities, B, the assessment of systems and processes, and C, other personal matters. Excuse me.
Thank you, members. One, just a quick preview for this coming month, the month of April, we'll have a healthcare financing workshop, and this is a continuation of our education series for the board. Here internally, we'll cover the waterfront of healthcare financing, and I think this is pertinent, especially with some of the changes coming down. So we won't dive into things specific like what we did with the LPPF, for instance, but just a larger primer on healthcare financing. We have a retreat that's coming up April 27th. My plan is to bring an initial outline, an agenda to the executive committee meeting that's been posted to get some guidance on the structure of that retreat. I will tell you right now, it's a short Saturday, and we have a lot of things in there, so we'll have to, many of you have given us some good suggestions, but ultimately I've got to have a way to call through some of that to make the day a little more manageable, but also to be able to give you the depth that you seek in certain topic areas.
What date is that again?
April
Saturday,
27th.
April 27th.
Through third and fourth quarter, you will see a steady amount of strategic plan updates as some of our project activities either come to a close, and we'll be bringing those to you. I think that's relevant because as you all as we enter into the budget season, having some idea about what strategies are working, why they're working, and if they're not working, why they're not working, to give you some idea about how to reallocate or make future funding decisions for the coming fiscal year. One in particular that I'll point out is what we're calling, it's a working title internally, we call it the decision matrix, and it is currently under Mr. Wallace's assignments. But as we look at how the landscape of funding is changing and how we need to be investing in assets, either bricks and mortar, or other modalities of care outside of bricks and mortar to bring care to individuals, especially with all these partnerships that you've all aptly noted, making sure that we have a sound decision-making matrix so that we're not doing this piecemeal. I think we're okay for now, but I don't want to get us in a position where we start making longer-term real estate decisions or investment decisions that really have a very short life, and it's hard to unwind those asset decisions. The last thing I'll bring up is the legislative process, and this is something a couple of you have talked to me about. And first I want to start out by apologizing to the board. Back in December when, and I was not there at this particular strategic planning committee, but having reviewed the presentations and talked to some of you as well as staff that were there was a pretty substantial presentation on the legislative process and around the principles that would guide our activities. And with my blessing, I said, yes, by all means, let's take this to the board to get some kind of guidance about where they wanted to go. It was at a very strategic level. Now, after talking to a few of you, I realize, and Manager Valdez, you've made this comment, I think, in a prior meeting, that you would have anticipated actually having a set of hearings around the development of legislation, if I understood you correctly.
As it was ongoing.
To be able to do that, we would have had to start this process probably back in the summer. And so it would very much mimic an interim committee of the legislature where you
Right.
start taking issues
That's right.
without any bills being drafted, and you start to formulate these and put the research around it, and then ultimately that leads up to legislative recommendation, which then leads to drafted language. And that is a pretty lengthy process, and it's something that I think that there needs to be some future discussion around this process. If that's what you all want to do, that's the board's prerogative, but we'll need to stack that on top of the budget development process. And for those of you that have been involved in legislative studies and interim studies like this, it can be time consuming. I'm not saying you can't do it, you're just going to have to figure out how you want to allocate your time. But again, the last thing I'll point out is that this is the first session where we've had two proactive pieces of legislation. The LPPF bill, which we're obviously working with conjunction with hospitals on, and the physicians hiring bill. Those are our two proactive pieces of legislation. So, I get the message loud and clear, and again, I apologize for not having what I would call an interim process, similar to what the legislature does to draft these bills. But I also think that as the session goes on, if it looks like there's going to be substantial amendments or committee substitutes, then we're going to have, I don't know that we'll have meetings scheduled to be able to do this, but I'll have to be able to find some way to very quickly, because the legislature won't wait on you, but to very quickly get some quick input on if a bill is amended thus, what's your thoughts on this?
That's right.
Because, let's assume that there's a certain range of allowance here in terms of going down and working with the legislature and advocating on behalf of our patients. But if something changes drastically, I'll need a way to bring this back to you. So I think we'll have to figure that out as we go along. Mr. Chairman, let's see.
Vice Chair.
So just two comments on that. I certainly understand the interim process and the fact that we have a rather lean staff here and it seems like we have many responsibilities for our staff. So weighing that versus the need for the board to be apprised of specific legislation. As we move forward, there may be some kind of middle ground, I'm thinking, between a full interim process with hearings and something that's just at a broad level, right? Where there's at least a preliminary list of potential bills that is brought before the board, both neutral, and proactive, although we're not typically proactive, we are here, something along those lines. And so that might be, we can examine kind of the full range of options before we get into the planning for the next session.
Understood, and it was, by design that when we came to the strategic planning committee in December, that we were staying at a very strategic level.
Right.
But again, I understand, given the comments, I appreciate it.
And, and that's, I'm just saying there might be some middle ground there, I'm thinking. On your other point, I'm sitting here trying to think how you could update the board, because sometimes these things happen while you're at the committee. And if that's the case, there's no way to update us. You are there, once a bill's been heard, it can be brought back up at any time with no notice again.
That's right.
Right? And so you could just be there and be called down there, and the chair could just say, okay, we're going to do this, and you all get in a corner. And so if that's the case, we have to trust the judgment of our professional staff, because that's the way it is.
And, and so Ms. Cavazos, she's actually at a conference right now, but we will continue to provide regular updates that she sends out on what's happening with legislation. I would propose that I think that if something were so drastic that I felt like, I just don't have the authority to say yes or no to this one way or another, I could either call an emergency board meeting, or I could call to see the executive committee. It's a little bit easier to pull a quorum together. To try to get some quick feedback on something, even if you all don't vote one way or another to endorse or oppose. At least I've got a little bit of guidance on where to go.
But that means everybody, we need
all hands on deck.
He needs to have cell numbers and be able to reach people like that.
Because otherwise,
Okay, with respect to the conversation that you and I had, I would like to be clear in stating that, yes, when the presentation was made in December, if there had been keywords used that would have, red flagged legislation coming down the pipe, especially from our own senator, who has worked with Central Health historically, okay? And if we had had that in advance, that is what I'm referring to. I'm not saying we have to be kept abreast of every phone call, of every conversation, of anything else. But if I know, that there is conversation ongoing between Central Health staff and the Senate or the House of Representatives regarding legislation that is going to impact Central Health, then we should be told that. When you're making your presentation, by the way, managers, be aware that this legislation is in the works right now and will be filed. So, and then tell us, basically, well, it's LPPF, it's 1142, whatever it may be, just like it could be SB 2112, okay? Which is also Watson's bill. All those things are going to have some impact on us, whether you may say, well, that's not our bill, or that is our bill, or we're proactive on the bill or not. If it's going to be regarding Central Health, regarding Travis County, I think that we should be kept abreast of any developing legislation. And yes, we don't need a full blown out, but we should at least get flagged that this is ongoing and not hear from it after the fact. And then when you ask and you find out, well, this has been in the development for months, then that to me is we've got a process issue. And I don't want to think it's a slap in the face to Central Health, but I would like to think that we're in such terms with our elected officials who represent us and who have fought for us, that they should have the courtesy of extending to us a heads up. That's all I'm saying.
The middle ground.
That's right. Give us a heads up. Or give the staff that you're working with, because you are working with them, you're not in a vacuum, so that they can give us a heads up. That's all I'm saying.
Andrew, would like to?
Thank you, Chair. Well, I just want to really go over something quick and then back to something else. I want to commend staff on that presentation. I was present, and I think it was a very thorough explanation of the process of legislative session. They provided a lot of useful material, I think, for the lay audience and those who are in the field itself. So I just wanted to give them credit for that opportunity. Another thing, that as you're moving forward with your updates, I hope at our next update that you'll provide us an update in regards to the mobile clinics and where we're at. I would love to see that. And I also urge you and the staff and everyone to become visionaries, to think holistically about the person around. So I just wanted to throw that in.
I'm sorry, could you say that last part again?
The whole person.
The whole person.
Look at it from a holistic perspective.
With respect to our patients?
Yes.
But I like to call them people.
They are, that's right, they are people, but they are also
So I
our
just want us
patients.
always to think of that as we are moving forward with our plans and progress in all our operations, to look around. So, and I know that you're all doing it, but again, it is our fiduciary responsibility and as a citizen to make sure that we always remind you.
It's our mission. We should all be doing that.
Well, again, thank you and happy birthday.
Thank you. Thank you, members.
Members, okay. An informational item, no action is necessary. Agenda item 10, the next Central Health Board of Management meeting will be held on April 24th, 2019 at 5:30 p.m. at Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. With that, do I hear a second? All in favor, say aye. All opposed, say no.
Aye.
It's your birthday. You have about 5 minutes, Mr. Dean.